So I'm aware there'll be a wide range of knowledge and experience in the audience. Some people will be experts in terms of their experience and their knowledge, and others may be learning at the beginning of a learning curve about CLL. So it's quite hard, it's quite challenging to know how to balance the talk in terms of what information I give you, the breadth and depth of information I try and communicate. So I'll start with some basics, then I'll move through to a little bit more detail, but try and focus more on the clinical and practical aspects and the real treatment questions, rather than getting into too much detail into the science. And we'll see how it goes, and you can question me by all means afterwards. So this is where I work, and some of you in the front will recognise the building there, which is about 10 years old now, and just still looking reasonably new. And we're quite a big centre in Nottingham. We're a university hospital. We're a regional centre for stem cell transplant, for clinical trials, and when we provide advice to our regional hospitals in Lincoln, Mansfield and Derby for patients with difficult problems, including patients with complex CLL needs. So we have lots of work to do, and our CLL clinics are getting bigger, and that's a good thing. It's because patients are living longer, and we're having more lines of treatment because the treatments have become more effective. But it's actually become a real problem for us clinically in delivering a service, because the clinic sizes are twice what they used to be, because people are living a long time, which is very good, but challenging. Okay, so what is CLL? Well, first of all, just to start with the terminology, because the word leukemia is obviously can be quite frightening when you first hear it. So it has various associations. Some of them are not necessarily relevant to CLL, but naturally will cause anxiety and so often fear at first usage. And as you'll know, it's very important how this is discussed. And you may all have different experiences when your doctor or your medical team first or subsequently discuss the word leukemia. So it actually comes from the Greek. It just means white blood. And so too many white blood cells. We use the word chronic in medicine. We use the word chronic to mean long-standing over a long period of time, whereas I'm aware that colloquially, particularly in Nottingham, I think, the word chronic is often used as meaning really bad, but actually chronic means over a long period of time. And then lymphocytic is the cell itself. So production of blood cells, hematopoiesis, which happens mainly in the bone marrow, is very complicated. But suffice to say that, let's get my pointer right, there we go. Suffice to say that the beginning of all blood cells starts with what we call a stem cell, and then it has multiple different steps where it can differentiate, it can change into a different type of cell, red cells, white cells, platelets, and CLL starts from a particular type of cell called a lymphocyte, and a particular type of lymphocyte called a B lymphocyte. So you may hear people talk about CLL as B-CLL, that's because it's a B cell. And B cells are found in most parts of the body. If you take a biopsy or a piece of tissue from almost any part of the body, the skin, the brain, the liver, any place you choose, you'll probably find some B cells there. They're blood cells that move around the body, and they have a very important role in immunity, in fighting infection, and producing antibodies specifically to fight infection and talking to other parts of the immune system. So B cells are very important. You can actually live with very few B cells. So, and without going into detail, you can actually remove a patient, a normal human being's B cells for a period of time with using drugs, and you can actually live with very few or no B cells. You'll run into problems with infections and other things, but you can actually live without B cells, just as a little aside. So they can be found in most parts of the body, but they're mainly in the blood, the bone marrow, the spleen, and the lymph glands, of course. And this is relevant when we think about the symptoms and signs that a patient with CLL may have. So who gets CLL? Well, it's relatively common. I think that the overall lifetime risk for an individual, for me or anyone else who hasn't got CLL, as far as I know, is about 1 in 200. So over your lifetime, the risk of getting CLL is actually not that small. So you'll probably know, if you haven't got it yourself, you'll probably know someone who has it at some point during your life. Absolute numbers, over 3,000 new diagnoses each year, and so there's a lot of people living with CLL at any one time, and that number, the prevalence, which is the number of patients at any one time living with the disease, is growing because patients are living longer and treatments are becoming better. The average age of diagnosis is around the early 70s, but I think we're increasingly diagnosing younger patients, and that's probably because of the increasing use of routine blood tests in primary care and GP practices. As it stands now, only about 10% of patients are younger than 55 at the age of diagnosis. I've certainly had patients in their late 20s and early 30s who've been diagnosed with CLL. So I think it's increasingly recognised, although still a bigger impact, but a minority of patients. For reasons we don't understand, CLL is more common in men than women. And my experience in medicine is that most diseases, and particularly the bad diseases, not necessarily talking about CLL, are more common in men than women. So maybe that's life getting its own back in another way. And there's no known cause. I mean, there's been various investigations to look at radiation or chemicals, and some of you may have read about this, but nothing's really been clearly linked to the development, the etiology of CLL. And our best understanding is that it's some sort of genetic accident that occurs within the genetics of the B cell at some point during its lifetime or its development. Our normal B cells are constantly rearranging their genes, rearranging their genetic material to learn how to fight new infections and to survive. And millions of genetic editing is going on every second or every minute of our being, and it only takes one or two accidents, genetic accidents within the cell, to cause a problem where the cell either won't die or will not stop growing. Okay, so how does it manifest? How does it present? How do we find out that patients have CLL? Well, increasingly, this is just what we call an incidental finding, or what you might call an accidental finding. You go to your GP for a blood test because you're 50 or 60 or 70, or you've got another problem, and you're found to have too many lymphocytes or too many white cells in your blood, and that provokes further testing or a referral. So this is usually in the context of a patient being completely well otherwise, and may have just been going for a completely different reason. So that's that's probably the commonest way that we actually diagnose CLL. And that can have pros and cons. Sometimes that can be a big problem because someone's perfectly happy, enjoying their life, and suddenly they've got leukemia, and they may have preferred not to have known. People have different views on this. Some patients like the idea of being diagnosed early because it can be monitored or have some reassurance and have some information. Others would prefer to not knowing about it, thank you very much, for another 10 years until it became a problem. And some of you may have had some experience of that. Other patients may have symptoms, so enlarged lymph nodes, and we have lymph glands in lots of parts of our body, the neck, under the arms, and then within our body cavities and groin areas. And patients who have an enlarged lymph nodes in their neck or under the arm, it's easier to find for the patient or their family or their GP to find, so they will then present. And those patients may have abnormalities in their blood. They may also have increased white cells in their blood, or lymphocytosis, or they might have a normal blood count and have what's referred to as SLL, and that terminology is slightly confusing sometimes for patients. SLL stands for small lymphocytic lymphoma or leukemia. It's actually the same disease as CLL. It's just part of a spectrum. Patients with SLL tend to have enlarged lymph glands, but a normal blood count, so no lymphocytosis in the blood. Patients with CLL tend to have a lymphocytosis, a blood abnormality. But basically, I think the way I'd encourage you to think about it is the same disease. It's a spectrum of the same disease. Whether you've got SLL or CLL, it doesn't really matter in terms of the tests and the treatment that we would recommend. But it can be a source of confusion sometimes for patients. Another way CLL can manifest is by affecting the production of normal blood cells, what I've referred to here as reduced bone marrow function. Our bone marrow makes red cells, white cells, platelets, all of which are needed for health, for life and health. If CLL becomes a problem and takes over the capacity of the bone marrow, just like weeds in a garden, that will push aside the flowers or the trees or the good growth of cells, and that could result in a reduction in red cell production, leading to anemia. And symptoms of anemia could be tiredness or shortness of breath, fatigue, or if you have a reduction in numbers of platelets being produced, you may bruise easily or have bleeding problems. That's less common as an initial symptom of CLL. Platelets tend to fall when the CLL is quite advanced, so that's not common, but it can happen. Infections, on the other hand, are a very common problem in CLL, both in CLL that's untreated, both in CLL that's undiagnosed, untreated, and untreated. So it's probably another talk in itself, really, but infections are a big issue in CLL that the clinicians and patients and their families need to be very mindful of. And I hope you're all going to get your flu jab when it comes in the next few weeks. So yeah, recurrent infections. So patients will go to their GPs with chest infections, maybe have shingles, maybe have sinus infections. The GP is not going to necessarily think, oh, maybe they've got CLL, but rather than the other way around, when CLL is diagnosed, and I talk to patients and I say, well, how have things been in recent years? Have you had chest infections over the winter? And you kind of pull out from the history, and very commonly patients will say, actually, yeah, in the last 2 years I've had 2-3 chest infections, have been difficult to clear. Oh, and I've had shingles a couple of years ago, and there are signs in the history that the immune system was becoming dysfunctional, or the immune system was becoming affected by CLL, although it's not always a prominent first feature, but it's often there in the background. So the infections we'd commonly see would be chest infections, sinus infections, or virus infections like cold sores or shingles, but a whole range can be seen. What we call systemic symptoms, what doctors call systemic symptoms, are symptoms that affect the whole system. So many of you will have heard of B symptoms, and when we talk about weight loss being a B symptom or sweats being a B symptom, but we have to be kind of very specific when we talk about these symptoms, because if you go out to the road and ask people if they have sweats or weight loss, many patients will say, oh yeah, I have sweats. But when we talk about sweats being due to CLL, we talk about drenching night sweats. So the intensity of the sweat typically at night is enough to change your bedclothes or your pajamas. So it's quite a dramatic sweat. And once patients have had them, they really know what a proper sweat is, rather than just being a bit hot and sweaty, or rather than having hot flushes, which might be due to other issues. So drenching night sweats. Weight loss, we talk about unintentional weight loss, unexpected weight loss of around 10% of your body weight. It's an arbitrary figure, but it's really just to put some sort of significance to weight loss, because everybody gains or loses a few pounds here and there during the year. But if you've lost a stone without trying, then that could well be related to CLL being a problem. You very rarely see weight loss or night sweats without anything else. So if you've lost weight or you've had night sweats, and yet your blood test is stable, and you have no enlarged lymph nodes or any of the other features I've described here, then it may well be something else is going on. So I think we have to be a bit cautious when we're interpreting some of these symptoms, because they're not very specific, because lots of other things will cause fatigue, will cause sweats, will cause weight loss, and usually that would go hand in hand. That would go together with your white cells in the blood going up, or development of anemia, or your lymph nodes becoming bigger. So any of these things in isolation we need to be viewed cautiously. And I would say the same thing about anemia, because patients with CLL become anemic for other reasons. You may become iron deficient, or you may have one of your medications causing anemia. So we have to be very careful when we interpret and look at the whole picture, and make sure we're not missing another condition or another problem that's distracting. And then lastly, just to say something that's not so unusual, but not common, is what we call autoimmune manifestations. So autoimmune means that your own immune system is attacking some part of your body. And in CLL, the autoimmune problems usually is when your immune system attacks your red cells and causes anemia, or your platelets and causes a low platelet count, which can lead to bruising or bleeding. And that's called ITP, when your own immune system reduces your numbers of platelets in your blood. So you may have a low level of CLL in your bone marrow, no enlarged lymph glands, be perfectly well, but suddenly your platelet count drops like a stone, and it's actually due to the CLL making your immune system destroy your platelets. That usually needs treatment. I won't go into the details of that, but it's not always necessarily needs CLL treatment. We can use other drugs to treat these problems that manifest with CLL. But these are not uncommon. Okay. I know many of you will know this. I'll just go through the basics fairly quickly. How is it diagnosed? Well, the blood test that we refer to is called a full blood count. That looks at your red cells, your white cells, your platelets. And what we call a lymphocytosis is an elevation in number of lymphocytes in the blood. That gives us a clue, but that's not diagnostic. But a lymphocytosis should then lead on to other tests, including a blood film, where we look down the microscope at the blood and look at what the cells look like. Again, this is not diagnostic. We can look at the cells and say this is probably CLL. So these are very suggestive, but they're not diagnostic. Usually, the most important diagnostic test to make a diagnosis is something called immunophenotyping, or another way of saying this in medical terms is flow cytometry. And without going into too much detail, this looks at the lymphocytes and tells us whether they're B cells or T cells. And if they are B cells, then it says, does this look like a CLL cell? And a CLL cell has lots of flags on its surface, and a certain combination of flags on the surface will tell us that it's most likely to be CLL. Sometimes that's not absolutely clear cut, and then we need to do other tests like a bone marrow biopsy or a lymph node biopsy, so taking a small piece of an enlarged gland or taking a piece of the bone marrow. And some of you may have had the not very pleasant experience of a bone marrow biopsy a number of times. Sometimes these are required to make a diagnosis, but I would say in most cases, maybe 3/4 of cases, probably a rough guess, we can get a fairly confident diagnosis just from a blood test using this technique called immunophenotyping, looking at the detail of the lymphocytes. Bone marrow biopsy may then be required later to assess response to treatment and for other reasons, but usually it's not required at diagnosis. Sometimes certain types of non-Hodgkin's lymphoma, and just give you a couple of examples you may have heard of. One is called mantle cell lymphoma, the other is called marginal zone lymphoma. Sometimes they can look a bit like CLL with a lymphocytosis in the blood and B cells that look a little bit like they might be CLL cells. And sometimes immunophenotyping, the blood test I referred to, can't distinguish, and that's when you may have to do a bone marrow test and another test to be absolutely clear that this is CLL rather than one of its cousins in the non-Hodgkin lymphoma field. This is what I call the blood film that I referred to just a minute ago. This is a very simple technique. You just take a sample of blood, it's smeared on a glass slide, and it's stained, it's washed and stained and fixed. And then we look down the microscope, and these little pale cells are your red blood cells. That's a normal looking red blood cell. It's actually an ellipse, that's why it's pale in the middle. And CLL cells are lymphocytes, and they're quite small, so they're not much bigger than a red blood cell, and they're fairly bland looking things. They have a big nucleus, which is the brain of the cell, which takes up most of the cell. And if you looked at a normal blood film and looked at a lymphocyte in a normal blood film, it could look quite similar to this. So looking down the microscope, you wouldn't necessarily say, oh, that's a CLL cell. You'd just say that's a lymphocyte. But some clues in this picture would be these things we call smear cells, which is basically where the cell is, during the process of making the blood film, the cell is disrupted and it bursts and it smears. And that's unusual to happen with a normal lymphocyte, and that happens more commonly with CLL, with patients with CLL. But like I said on the previous slide, this is looking down the blood film and saying, oh, this looks like CLL, because certainly there are too many lymphocytes. There shouldn't be this many in this field of a microscopy. You don't really know it's CLL until you do the immunophenotyping test or the flow cytometry test that I referred to a minute ago. So you'd bet a reasonable amount of money that this is going to be CLL, but you really need to have the confirmation on the more advanced diagnostic tests. Okay. What about prognosis? It's something everybody quite reasonably wants to know. What's my prognosis? I've got CLL. It sounds terrible, and then maybe it doesn't sound so terrible after you've had a bit more information. But what's going to happen? What's going to happen in the future? What we call the natural history of CLL. The problem is, and it's often not very helpful for patients to hear this, but it's a very variable condition. And the medical word we use is heterogeneous, which means it's extremely variable from patient to patient. There are some patients who have a decade or two in front of them and never need treatment, and particularly if you're diagnosed in your 70s, for example, which is not uncommon, then many of those patients, maybe a third or even a half of patients, may never need treatment. So that's at one end of the spectrum. The other end of the spectrum is that some patients have particular genetic problems with their CLL cells that I'll talk to you about in a second, which means that certainly in the past with traditional chemotherapy, it was very difficult to treat, and we were looking at a much shorter prognosis. And so you have a really wide spectrum of prognosis that you can't always tell at the beginning. I mean, we're getting better at predicting prognosis from some of these genetic tests that I'll talk about in a few minutes. But we're still not perfect, and really this is one of the problems with the active monitoring or watch and wait, whichever terminology you prefer to use, is the uncertainty and following the trend of your blood count and knowing how much to worry, how often to be tested. These are all real issues for patients, and I think we're getting better, but there's still a big degree of uncertainty, which is uncomfortable, I think, sometimes. So, as I mentioned, excuse me, a significant proportion of patients will never need treatment, and that partly depends how old you are when you're diagnosed, because if you're diagnosed when you're 85, then even if you're destined to live to 100, for example, then you may still not need treatment. If you're diagnosed when you're 40, hopefully you'll have a long life expectancy ahead of you, and by definition, therefore, you're more likely to progress over 2, 3, or 4 decades. So, I mean, that depends a little bit on when you're diagnosed. There's a proportion of patients, maybe a quarter or a fifth, and it's difficult to pin this number down. And this figure is based on patients who require treatment, by the way. So this is not of all CLL. So if you look at all CLL diagnosed, that's probably about half of that, so 10 to 15%, have what we call high-risk disease. And I'll talk a little bit about that in a minute. Some of those we can identify with current tests. We can say to this patient, you have high-risk disease, and by high risk we mean you're more likely to fail treatment, you're more likely to relapse after treatment and have shorter remission. Some of those we can identify, but not all of them. And we certainly can't identify that easily at diagnosis. We can identify that more commonly pre-treatment, but you don't always know that until you've had one treatment and failed the treatment or had a short remission. And these are the patients really that we need to improve treatment for, and certainly that's happening. And I'll come on to different drugs in a few minutes. Okay, so trying to work out the risk of CLL. Sorry, I might just have some water for a sec. So there's different ways to look at risk, but probably the most important risk and the most important test that can be done, and we should all patients should have these tests before they start treatment, not necessarily at diagnosis, but certainly at the point that treatment is being considered. These things you may have heard of, which are genetic factors called 17p deletion, which is done by what we call a FISH test, and a very similar, a related test called TP53 mutation. So TP53, I don't want to get too technical here, but TP53 is a gene, and that gene is on the short arm of chromosome 17. So we've all our cells have chromosomes, and chromosome 17 carries this particular gene. It's a very important gene, and it's important for normal health and normal cell function. But it's disrupted, it's either mutated or deleted in lots of different human cancers. So most cancers of any kind, blood cancers otherwise, have some patients where P53 is playing a role, is a problem. And it's particularly associated with resistance to chemotherapy. So it enables the cell to survive even when chemotherapy has damaged the cell. So it's very important. These tests can be done, so nearly all hospitals can test for 17p deletion using this test we call FISH, and then increasing numbers of hospitals can test for the P53 mutations. So they're two different tests. The consequences are the same, but you need to have both tests done because it's possible to not have a deletion but yet to have a mutation. So you should ask your doctor before each line of treatment whether those tests have been done. until recently, it wasn't that easy to get the P53 gene mutation test done. But now there's an increased number of laboratories in the country, and the NHS is now paying for it routinely, whereas a number of years ago it wasn't. It was only being done within research. But both of these tests are now recommended in the British guidelines and should be done at every line of treatment. And the reason they're important is because if you have a 17p deletion and or a P53 mutation, then chemotherapy won't work at all or won't work very well, and chemotherapy shouldn't be used. So it changes the treatment decision, and that's an important concept in medicine. If you're going to do a test that has a significance in terms of its prognosis or in terms of its, or you get an answer from a test, then you need to know, what am I going to do with this answer? And the answer, and the issue here is, yes, we can do something with the answer to this question, because if you have one of these problems, then we would change our treatment plan and not use chemotherapy. When patients first have treatment for CLL, maybe up to 10% of patients will have either a 17p deletion and or a P53 mutation. So it's still a minority of patients. So I tell patients, 9 out of 10 chance you won't have this problem, but it's a very important problem not to be missed. In subsequent lines of treatment, so once patients have had treatment and then relapsed and then maybe had another relapse, this P53 or 17p problem becomes more common. So it depends at what stage of the disease it's tested, but at first treatment, it's around 10% or so. The other genetic test that I thought it was worth mentioning, without wanting to blind you too much with terminology, which is becoming, it's been known for a while that this is important, but it's only recently really that we can say maybe we should be treating patients differently. Something called IGHV mutational status, which is a real mouthful, and it's to do with the immunoglobulin gene. So B cells make immunoglobulin, which is antibody, and the gene, and part of the gene that's involved in that can be either mutated or not mutated. Now, even more confusingly, in this situation, having a mutated gene is actually a good thing. And that's the opposite to nearly everything else in medicine, where a mutated gene is bad. But this really shows us there are two types of CLL. There's the CLL that has a mutated IGHV, that has a better prognosis and generally do very well with chemotherapy and can have long remissions with chemotherapy, or unmutated IGHV that tend to do less well with chemotherapy. The prognosis is not quite as bad as patients who have a P53 problem, but I think we're moving in a direction now, we're not quite there yet, we're moving in a direction now where patients with unmutated IGHV probably won't be treated with chemotherapy in the future. I think that we're kind of on the verge of that becoming a reality, but we're not quite there yet. So we're getting to the stage where we've had this test for a while. We've always known that there are two different types of CLL in relation to this. We've known that the prognosis is different, but in the past we've never really been able to do much differently. But now we have newer drugs and different ways of treating CLL. It may be we'll be using this to make a treatment decision as we do for P53. So I hope that makes some sense. And without going into the detail, lastly, just to mention that there is increasing evidence for other genetic markers to identify patients with high-risk CLL. We know that these P53 tests can identify up to 10% of patients, but that's not all patients with high-risk CLL, because we know that 20 to 25% of patients will relapse early after chemotherapy. So we're missing another 10 or 15% of patients who've got high-risk CLL who don't have a P53 problem. And there are other genes that have been identified that we think that are being nailed down as being as very important, and that's come about through, you may have heard of the NHS has a big Genomics England project where they're doing whole genome sequencing, so sequencing every single element of the human genome. And actually the UK has been quite leading in terms of moving forward with the genetic screening in this way. And through that programme, the CLL community has been quite engaged with that programme. Through this Genomics England programme, the whole genome sequencing, led by Anna Shue in Oxford, we're getting quite close now to being able to clearly say which genes are important, as well as P53. And I think within a small number of years, many patients, if not all patients with CLL who are needing treatment, will be having their whole genome sequenced, and we'll be able to say very clearly, you've got high-risk CLL, you need to be treated in this way, you're not too bad, you can have this treatment. And I don't think we're too far from that. It'll probably be a number of years, but certainly won't be decades. And the most important other thing to say about this is that the participation of patients in clinical trials, so having treatment within a clinical trial protocol, which can have advantages for patients, also gives massive amounts of information about the genetics of CLL and about the prognosis, and that information is being used. It's not just being shelved away somewhere and forgotten about. It's being used actively to look for better ways of predicting prognosis and then looking for ways to treat those patients differently. And I think it's fair to say the UK CLL community has been quite leading in this area, and I don't think we can say that about all our areas of blood cancer or other areas of medicine. Right, so that's enough on the genetic risk. I said a few minutes ago that not everybody with CLL needs treatment. In fact, there may be a significant proportion of patients who never need treatment. And so a reasonable question to then ask is why would you need, when do you decide to treat a patient or not treat a patient? What factors influence the decision about needing treatment? And these are fairly well established actually, and most of them are fairly logical, and patients can reconcile them quite easily. So the first thing to say is that if there's a rapid increase in the number of CLL cells in the blood, and there's something that we call the lymphocyte doubling time, which is exactly what it says on the tin, which is how long it takes for the number of lymphocytes in your blood to double. And many patients have a slow lymphocyte doubling time of a year or 2 years, and you can look at their graph and it slowly increases, and we can watch, and we safely watch, and the patient's perfectly well, and we don't need to rush in and use treatment because there's no advantage as it stands of doing that. Other patients have a rapid lymphocyte doubling time where their numbers of cells are doubling within 3 months, for example, and those patients are on a fairly quick trajectory towards needing treatment. So. And the only caveat here is that sometimes there is another reason why that might happen. So if you have an infection or you have an operation or something else traumatic or an insult happens to your body, your lymphocyte count can shoot up. So you need to be clear there's no other reason that your lymphocyte count's gone up, and it needs to be sustained. So sometimes we see the lymphocyte count jump up. There's a potential conflicting explanation, and we just have to sit tight and wait. Sometimes it settles down again, and you just have to maybe not be too precipitous in making a decision. But if there's a rapid increase with no other explanation, that's often an indication to start thinking about treatment. And often that goes hand in hand with the development of anemia. So your red blood cells levels drop, you become anemic, you can become tired, short of breath when you're climbing the stairs, and certainly development of anemia or development of a low platelet count, which could lead to bruising or bleeding. These are indications for treatment. This is when we say, look, the time has come now to start talking about treatment. Usually these things don't happen quickly. Usually you have a number of months at least to confirm and to discuss and to decide. So the advantage of CLL, from my perspective, compared to other diseases that we treat, is that you nearly always have time. You don't have to make an urgent, or certainly don't have to make an emergency decision. Sometimes patients have, and patients are very variable. Some people have very small lymph glands and have very high numbers of cells in their blood. Some patients have quite bulky or chunky or glands that are easily visible or are causing a problem. And this could be an indication for treatment if they're progressively getting larger or causing problems. And I just want to mention one line on this condition or this phenomenon that you may have read about or heard about called Richter's transformation, which is named after a German. Nothing to do with it being an aggressive condition, it just happened to be that he discovered it. And Richter's transformation is where the CLL changes its spots, it transforms, it's still a B cell, but instead of being a slow-growing, what we call indolent condition, it turns into an aggressive lymphoma. Usually it's an aggressive non-Hodgkin's lymphoma. And the risk of that happening to any particular patient with CLL is quite small. It's only about 1% or so a year. But it's a big problem if it happens. It can be treated, but we really need to know about it. So for example, if there was one lymph gland that was getting bigger very quickly, If a lymph gland suddenly went from 2 centimetres to 6 centimetres in a couple of weeks, then we would want to exclude this phenomenon of Richter's transformation. And the way to do that is to do a biopsy of the gland and to say, is it CLL or is it Richter's? Because they're treated very differently. It is rare, but it's important, which is why I just mention it. So, but CLL itself can often cause enlarged lymph glands, and that might be an indication for treatment. The other thing that can happen to patients, and often this creeps up on people without them knowing it, is that their spleen, which normally, your spleen is about the size of your fist and sits under your ribs on the left-hand side and has an important role in your immune system and in your blood surveillance, shall we say. Instead of being the size of your fist, the spleen can slowly enlarge, and it can become very large indeed. It can become 3, 4, 5, 6, 7 times its size and take up half the abdomen. That happens very slowly, and sometimes patients don't notice it. Sometimes patients have indigestion or feeling of fullness, and they can't eat their large Sunday roast anymore. They can eat small portions of food because their stomach's squashed by the spleen. But that should be easy to determine by your doctor by just feeling your tummy, by examining your abdomen. And so if you ever have any symptoms in your abdomen that you might be concerned about, then it's usually quite easy to determine just with a simple clinical examination whether your spleen's big or not. And if there's any doubt, then we can do a scan, an ultrasound or a CT scan. And as I say, it can creep up on you, so it can happen slowly in the background without you knowing it. But that can be an indication for treatment if your spleen's becoming very big and causing trouble. The other indication for treatment is these symptoms I referred to earlier on, called B symptoms, which is unexpected weight loss of about 10% of your body weight, or so drenching night sweats. And again, just making sure that these are due to the CLL. Usually that goes hand in hand with abnormalities in the blood or lymph glands as well. And I also mentioned earlier these autoimmune complications where the immune system attacks your red cells or your platelets and pushes them down. That can be an indication to treat CLL itself sometimes. So this isn't completely comprehensive, but there are sometimes other reasons to treat patients with CLL. For example, recurrent infections. If patients are having problematic infections that can't be controlled with antibiotics, and we think that treating the CLL might improve that situation, that can be quite a difficult decision to make sometimes, but that might be a reason to talk about treatment. So this list is not exhaustive, but these are the commonest reasons that we may think about taking a decision with the patient to treat CLL. Right. I wanted just to spend a couple of minutes talking about this area, which is becoming complex and also quite difficult conceptually for patients sometimes to understand, which is if there is a treatment available for CLL, why can't we use it? And there are different answers to that. It can be a long answer, so I thought I'd try and just summarize it briefly. So the first thing to say is that the clinical evidence that a treatment works, so a clinical trial has been performed and we've shown that treatment A is better than treatment B in a particular situation. The licensing of a treatment, which is where the regulatory authorities legally approve that drug to be marketed in a particular territory, a particular country. And then thirdly, the funding of that drug. Those three things do not always align nicely. You think they should. The sequence should be that a trial is done, and usually what we call a phase 3 randomized trial, where you have a few hundred patients who have drug A and a few hundred patients that have drug B, randomly allocated, and then we show that drug A prolongs remission and maybe prolongs survival compared to drug B. That would usually then be required to lead to regulatory approval, which is called a label or called a license. In the US, in North America, that's the FDA, the Federal Drug Agency. Then, as a general rule, they're normally quicker at giving licenses than the EU, and we can discuss all the reasons that might be. In Europe, where I think we still are, it's the EMA, so the European Medicines Agency, which actually moved its headquarters from London to Amsterdam, I think, as soon as Brexit was delivered by vote in 2016. Just so you know, so actually moved its headquarters, so it's not in the UK anymore. But we're still in the in the EU. So the EMA are still the body that decide whether a drug can be licensed and therefore legally marketed in the UK. There is another body in the UK that deals with the safety of medicines called the MHRA, which is slightly different. But in terms of the license, the legal permission to market the drug, it's the European Medicines Association. So you get your result from the trial. Drug A is better than drug B, and in a meaningful way, and is safe. The FDA or the EMA say, okay, the license is granted, but that doesn't mean that the drug is funded, because once you have regulatory approval or a license, it depends where you live, and healthcare systems vary all around Europe, never mind around the world, and people's ability to pay for drugs varies as well. So we can sometimes get into difficult situations where we have good evidence that a drug works, but the license isn't yet granted, and there are examples of that in lymphoma at the moment in Europe. And then you can have examples where a drug where there's evidence that it works, there's a license given by the regulatory authorities, but it's not yet funded, or it's never going to be funded by the healthcare system within which you live. Of course, if you have private insurance or you have millions of pounds in your bank, then the last issue is not so much of a problem. Although I should just briefly say on that last point that even having private insurance isn't always sufficient to pay for all of these expensive cancer drugs some of which I'll talk about in a minute. So it doesn't have absolute coverage. Okay, so we live in the UK, we live in NHS England, as it's called, and what we call cost effectiveness, so whether a drug is deemed to be effective enough to be worth the money, is determined by this organisation you'll have heard of called NICE, the National Institute for Clinical Excellence. And the way this works is that the pharmaceutical company gets its license, so they have their evidence, they get their license from the European authority. They then take the dossier, the portfolio of evidence to NICE, and they submit and say, we'd like you to fund this within the UK. Quite a long process, many months or sometimes up to a year. And at this stage, they do ask for clinical expert input. So for CLL drugs, I've been involved in providing evidence to NICE on CLL drugs. So they do seek relevant input at that stage. But the decision is actually rests with health economists. So not with doctors, but with essentially statisticians who decide whether the benefit in terms of survival or remission duration is worth the money that the drug is being sold at. And NICE are actually quite good at negotiating with drug companies. They do it in commercial confidence, so we never know the final price that NICE agree with a drug company, but they are quite effective at bringing the price down compared to other healthcare systems in other territories. And in fact, other countries around the world look to NICE, and if NICE approve drug A for CLL, then other countries' healthcare systems sometimes say, okay, that's good enough for me, we'll fund it as well. But they never know exactly what price the NICE has negotiated. But it's usually certainly less than the US price, that's for sure. Okay, so, and this has become very important for CLL because within the last 5 years, I've probably lost count, but there's at least 6 or 7 new drugs that have been both licensed and funded for CLL. And that's actually quite remarkable, and I'll show you some historical information in a minute. But even compared to other blood cancers or other types of solid organ cancers, there's probably not been as much progress in other cancers as there has been in CLL in terms of new effective drugs being licensed over a relatively short time frame. And the NHS, I have to say something slightly positive, it's actually been quite good at funding these effective drugs. It's not perfect, sometimes it's a little slow, but actually it's funded, approved funding for the major effective CLL drugs relatively quickly after license. So I think in this situation it's been quite good. Right, just a bit of history briefly. If we just go, this is a timeline, if you can see at the back. So we've got 1960, 70, 80, 90, turn of the century, 2010. I'm stopping there for the moment. We had decades of treating CLL. I wasn't treating CLL here, obviously, but there were decades when CLL was being treated with only one drug, chlorambucil, which is still used, and it's still a good drug for CLL, so that stood the test of time, but there wasn't much choice then. In the early 90s, this drug fludarabine was developed, and there's almost certainly some people in the room that have had fludarabine as a single agent or in combination with other drugs. A number of years later, in the late 1990s, fludarabine was combined with cyclophosphamide, what we now call FC, and that was a big step. Around the same time, probably a few years before, we started to use stem cell transplants from a donor, a sibling, or a matched unrelated donor, as quite a drastic treatment for CLL. But at that stage, we didn't really have much else. So if you're a patient in the 90s and you were relatively young and fit and you had fludarabine and that didn't work, or your CLL relapsed, you didn't have really many options left, and transplant was quite commonly used then. And it was quite a blunt tool, but it was very effective for some patients. Then we got a number of additional chemotherapy drugs. So we worked out that F plus C, so cyclophosphamide plus fludarabine, was better than fludarabine alone. And then a number of years later, after in about 2007, 8, more than 10 years ago, the big German trial showed that adding rituximab, which is this antibody, this targeted treatment to B cells, adding rituximab to FC chemotherapy was better than FC. So this is kind of an incremental, step-by-step improvement of first-line treatment. And then there's a couple of other drugs here you may recognise. Bendamustine is still used sometimes for patients who can't tolerate FC, quite similar. Alemtuzumab is not used so much anymore, but very occasionally. In kind of difficult situations it could be considered, but that's really fallen out of favour now because of the newer drugs that we have. And I'll update that timeline in a slide or two. I'm just going to show you two slides here just to try and show you a concept rather than go into too much science. Oh, and that hasn't worked at all. I don't know. So that's got, oh no it has, there we go, sorry. Oh, it got lost in translation from the Mac. So just in terms of just communicating concepts, and this is just to give you an idea of how the community, the scientific and clinical community, have tried to develop better treatments for CLL. Most of the drugs I showed you on the previous slide was really what we would call empirical trials. So giving one drug, that works quite well. Oh, let's add another drug, that works a bit better. And then adding an antibody, that works even better. So they're more kind of practical empirical trials rather than really understanding the disease and trying to say, well, why does the CLL cell survive? How does it survive? And therefore, we can understand how it might survive in order to determine how to kill it. And in terms of concepts, there's different ways to think about it, but one way is as follows. One is to say, how do the CLL cells survive within the bone marrow, within the spleen, within the blood? And we think they probably get help from other cells, so what we call the microenvironment, which is the niche that they live. They have friends or they have other cells around them that help them survive. So that's what we call the microenvironment. And you may read about that if you're an avid reader of CLL science. Another concept is that the B, we now understand better how the B cell, the CLL cell, survives and grows. And there's something very important called the B cell receptor, which is a molecule that sits on the surface of the B cell, and it's very important in receiving signals and transmitting those signals to the cell and telling the cell to proliferate, to grow, to divide. And we've learned how to target that mechanism with treatments. So that's been important for drugs like ibrutinib or idelalisib, which you may have heard of, and a number of other drugs coming down the line following those two first-in-class drugs. Those drugs have been developed by our scientific understanding of this. So they haven't just been pulled off the shelf and thrown into a patient. They've been developed through our scientific understanding. And that's why we really encourage patients to contribute to trials, to contribute blood samples for biobanks and for research, because it's without those real CLL samples it's with those samples that we really understand better how to treat CLL. Thirdly, and this is important to a drug called venetoclax, which many of you may have heard of, is understanding why the CLL cell doesn't die when it should do. So most cells of our body will receive signals to develop, to grow, and then there comes a time in that cell's life where it's either instructed or programmed to self-destruct and disappear and leave room for a new cell to to be developed. CLL cells is that there's a problem with both growth, so growing too much and proliferating and dividing too much, so a growth signal, but also a signal to tell the cell to not die. So there's a signal to the CLL cell to say, keep living, don't die. And that's an abnormal signal that helps the cell survive and accumulate. And by understanding those mechanisms of why a cell may survive when it shouldn't, so it's like a child not doing what it's told, it just keeps going, whatever you say to it, him or her. Then by understanding why a cell may not switch off and die like it should has led to the development of some drugs like venetoclax, which tells the cell to die. So this was just really just to communicate that these concepts of understanding CLL and how understanding the science and the biology helps us develop treatments. And this just illustrates this, and this is from Pete Hillman in Leeds, who's been the UK lead for most of our trials and new drug development. Just to communicate this concept of the balance. This is a balancing scale of the balance of cell growth and cell death, and in normal health we should have a fine balance of that. We should have, broadly speaking, the same number of B cells being produced as the old B cells dying, and we know in CLL that there's always a certain proportion of cells, and it varies according to where the cell is, but there's always a certain proportion of cells that are growing, that are proliferating at any one time. And a very important part of that, driver to that, is the B cell receptor, which I mentioned before, which ibrutinib and idelalisib and these drugs target to switch off this proliferation. And then the other side of the balancing scales is the failure of the cell to undergo apoptosis, which is the medical term for cell death, programmed cell death. And there's a protein within many of our blood cells called BCL2, and that tells the cell not to die. So if BCL2 is switched on, it tells the cell not to die, to keep living. So if you can disrupt this protein, and it's much more complicated than one protein, but this is just an example, if you can disrupt this protein and switch off the do not die signal, then the cell will die. So it's this balance between cell growth and cell death that we've tried to address with the new drugs, and I think we're definitely making good progress. And there's an example of that in a few minutes. Right, going back to my timeline, you'll see I've cut off everything before 1990 because not much happened before then. The pale drugs, I've actually the drugs that are now in pale grey font are the ones that we're not really using anymore. So we don't really use fludarabine on its own. We still use it in the context of the FCR treatment. We don't use FC on its own because FCR is better. And some of these other drugs have been usurped or superseded by some of the other drugs. We still do occasionally use allogeneic stem cell transplant, so using a bone marrow stem cell or bone marrow transplant from a donor, from a matched sibling or unrelated donor. But we're doing a lot fewer of these transplants than we did before, only because the drugs that we have to use to treat CLL and that are safer are much better. But there's still a role for transplant for selected patients. We're still using FCR or RFC, depending on how you want to call it, which is the main immunochemotherapy for relatively fit patients as first treatment. But then you see a whole host of drugs that have come in the last 5 years. You'll have heard of obinutuzumab, which is like the son or daughter of rituximab. It's a slightly better antibody than rituximab. Ibrutinib, which was a complete game changer, which is this orally administered tablet drug which targets the B cell receptor pathway. A similar drug called idelalisib, which is probably almost as good as ibrutinib, but it has a lot more side effects and it's fallen out of favour a little bit. And then this drug venetoclax, which tells the cell to die, and I'll come back to some of these drugs in a few minutes' time. And then from here on, there are various combinations. So now we're learning better understanding how to combine these drugs. We know ibrutinib is a good drug. We know venetoclax is a good drug. We know obinutuzumab is a good drug. The question now is how do we combine those together, and how do we sequence those together? And that's what the trials that we're doing at the moment are looking at. I have to mention this technology called CAR T-cell therapy. I'm not going to talk about it really much at all. It's really only on the horizon in CLL. There's a trial starting in the UK in the next few months in 2 or 3 UK centres. You may have read about this in the newspapers. It's a T-cell treatment where the patient's good cells, they're good cells called the T cells, are modified, taken out of the body, modified, and then returned to the patient to target the cancer cell. And the NHS has approved this treatment for certain types of lymphoma, and we've had some patients who've had this treatment. It's just on the horizon for CLL. It may be important. Some people believe this treatment, this technology, may mean that we don't need to use stem cell transplant anymore. I think it's an open question, and it'll take a few years, I think, to sort this out. But this could be quite a useful treatment when the drugs have failed. That's probably the best way to remember it, but it's just on the horizon at the moment. Right, so coming back to more practical questions. So we're in the NHS in England in 2019. How do we make a decision about first-line treatment? So by first line, obviously we mean a patient who's never had treatment before. They've diagnosed with CLL, they may have undergone a period of watch and wait, they now have problems due to their CLL necessitating treatment, anemia, big glands, and all the things we talked about earlier. What are the three things we should consider? There are lots of factors to consider, and I haven't been very patient-focused here in talking about the patient's own wishes and the patient's social support and the patient's various other factors which are very important to you all. I've just tried to focus more on the kind of the medical or the objective factors. That's not to dismiss the other things, it's just to make it a bit of a cleaner talk. The first thing is the thing I mentioned a number of times, which is this issue about P53 or 17p. It's really crucial. If you're going to have treatment, you need to know, are you P53 mutated, are you 17p deleted? And as I said before, it's only about 10% of patients at first treatment, but that's really crucial to know that. If that is the case, then chemotherapy is not appropriate. You should not be having chemotherapy, and you should be having one of these new targeted drugs that I've mentioned. And most commonly, this would, in 2019, this would be ibrutinib, given on its own, three pills a day, although the company are now making it into one pill. If anyone's on ibrutinib, you might be getting one pill instead of three in the near future, but maybe not if you're on a trial. But so that's the most commonly used drug for patients with a 17p problem. Occasionally there are patients who are not suitable for ibrutinib, and I'll maybe come back to that in a minute or two, and in that situation venetoclax or idelalisib may be considered. So we do have options for these high-risk patients for first treatment, so these patients are no longer having chemotherapy. The second issue is the fitness of a patient, and this is a big area of debate among clinicians, and I'm sure it would be amongst the patient and family groups as well, because how do you determine fitness? What is fitness? Well, broadly speaking, we would consider fitness by determined by what treatment you want to give the patient. And when we're thinking about first treatment for CLL, without the P53 problem, the standard treatment we were still using in 2019 is FCR. So fludarabine, cyclophosphamide and rituximab. So 2 chemotherapy drugs given as a tablet plus this antibody drip. Now that's quite strong treatment. It hits the immune system quite hard. It's not for the faint-hearted. But it can be given to patients, and we don't have age as an absolute cut-off, but it can be given to patients up to the age of 70, maybe in their early 70s, as long as they don't have any major medical conditions. If the kidney function is quite good, and the heart function is quite good, and you're a quite fit 70-year-old without other major medical problems, then FCR is possible. So it's not just for the very young, but we do start to worry about FCR in terms of the side effects and the risks once patients are over the age of 70, or if they have other significant problems like chest problems, heart problems, kidney problems. So that's a discussion and a decision to be had with your doctor, and it's a very personal, individualized decision. But people and clinicians will define fitness differently. If you ask 10 hematologists to define fitness for FCR, you'll get slightly different answers, and that's not because they're wrong. It's just because there's a bit of an art to medicine as well as science. But as a general rule, if you're reasonably good for your age without too many medical problems and you're under the age of 70, then FCR would be considered to be the standard treatment if your P53 gene is okay. And the third factor, which we should never forget, is whether there's a clinical trial available and that's suitable for the patient. And I'll talk at the end. I'll talk about the FLAIR trial that I know some of you in the room have participated in, which has been a really important trial, both for patients and doctors, giving access to new drugs to patients before they're funded, and for us learning about the different treatments for CLL. So you should always ask about a clinical trial at your hospital, and if there isn't one at your local hospital, you should ask whether there's one perhaps at your nearest regional centre. If you're willing and able to travel, it's often worth considering that if your hospital doesn't provide that particular trial. So I'd definitely encourage you to do that. So we can usually, based on those factors and some other general discussion with the patient, we should then be able to decide what treatment to give as first treatment. So, as I mentioned just on the previous slide, patients who have a P53 problem, almost irrespective of how old they are or how fit they are, I've had patients in their late 80s who've had ibrutinib without any trouble, so we're in a situation now where actually the fitness or age of a patient is much less relevant with the newer drugs because they're much safer and much more tolerated. Ibrutinib is most commonly used, but we do have these other drugs as an option if ibrutinib is a problem. And ibrutinib could be a problem, for example, if you have significant heart problems, if you have a very weak heart or you have a tendency to irregular heartbeats, we might get a bit nervous about ibrutinib because that can cause irregular heartbeats or problems with the heart, which can be serious. Or if you have a tendency towards bleeding, if you're on a drug called warfarin, which is a blood thinner, then we get very nervous about ibrutinib because there is a small but significant risk of serious bleeding. So these are just two examples of reasons why we might not always choose ibrutinib, and we might then turn to one of the other targeted drugs. But we do have options, which is very positive, and we didn't have a few years ago. A fit patient, we talked about that a second ago. If you're reasonably fit and you're under the age of 70-ish, and without any too many medical problems, then FCR remains the standard first-line treatment. Now, this is getting a little bit controversial because there's recent trial results from North America, from the United States, showing that ibrutinib is superior, giving ibrutinib to patients as first treatment compared to giving patients FCR. Ibrutinib is better in terms of duration of remission. It doesn't mean patients will live longer, we don't know that yet, but patients will have a longer remission on ibrutinib compared to FCR. Now, we're in a bit of a situation in the UK where we're doing a very similar trial ourselves, which is actually bigger and we would think better, which would, and I'll come on to that and tell you a little bit about that in a few minutes. And that trial is likely to finish early next year, and we may have results sometime next year. It's not always easy to predict, but we're getting to the point, the cusp, where we may not be using chemotherapy at all for CLL, because the main use as it stands is first treatment for patients who don't have a P53 problem. And that's still considered to be the standard therapy. It can be very good for a significant proportion of patients, but we're getting to the point where the newer drugs are demonstrating their superiority. So it's certainly a space to watch in the next year or two, and not much longer than that, I don't think. What if you're less fit? What if you're 78 and you've got a couple of medical problems and you're not good enough to have FCR, your fitness isn't sufficient and there's too many risks? Well, there are other alternatives, and there are various options, but probably the most commonly used treatment would be good old chlorambucil, which has been around for decades. It's a tablet chemotherapy drug, very well tolerated, doesn't cause sickness or hair loss or the usual things that you get with other chemotherapies. Combined with an antibody drug, this drug called obinutuzumab, which is like rituximab, targets the B, it's a drip, given as a drip, targets the B cell like a homing missile, and generally well tolerated once you get past your first dose or two. And actually, elderly patients, older patients can do very well with this combination and often have a few years of remission before they need further therapy. So there are good alternatives even if you're a bit older and a bit frailer. This is not the only option in this age group. We mentioned bendamustine earlier. Bendamustine probably falls somewhere between FCR and chlorambucil in terms of its strength and in terms of its side effect profile. It's less commonly used now, but you may have had this, or your doctor may have talked about it, or you may have read about it. Just like FCR is being challenged by ibrutinib and other treatments, Obinutuzumab and chlorambucil has recently been challenged by a combination of the same antibody obinutuzumab with this drug venetoclax, the one that tells the cell to die, a tablet. It's not a chemotherapy, it's a targeted drug. And there's very recent evidence to say that obinutuzumab plus venetoclax is better than the conventional obinutuzumab chlorambucil. Now, by better, I mean it produces a longer remission, but again, it doesn't necessarily mean that you're going to live longer or that your overall survival is going to be improved. But because if you fail any of these treatments first line, you know that you have ibrutinib as a second option and other drugs that I'll talk about in a second. So thinking about not just which is the best treatment for now, but thinking about what treatment could I have as my second treatment or even as my third treatment, and how will these impact on my quality of life, my side effects, and what's the bigger picture? Are they going to affect my survival? Are all complicated factors to consider. And we don't know the right answer yet in terms of the sequencing and the combination of these drugs. We're almost spoilt for choice, really, in a way. So that was all first line treatment. That was all first treatment for CLL. What happens if your CLL comes back? You may have had FCR, you may have had chlorambucil, obinutuzumab, one of the other treatments. What happens if your CLL comes back? Well, now in 2019, we rarely use chemotherapy. There may be particular patients with particular characteristics where chemotherapy is used a second time, but that's pretty unusual now. The only potential advantage might be that chemotherapy is a fixed duration treatment, typically 6 months for a duration of treatment. So it may be that a patient who had chemotherapy 10 years ago had no problems, had a 10-year remission, which is much longer than average, and may wish to choose chemotherapy again if they're young enough and fit enough, because they just want a 6-month defined treatment duration. Do my treatment, then stop. It worked very well last time. Thank you very much. That's not unreasonable, but that would need a careful discussion with your doctor. But as a general rule, having chemotherapy twice, it does carry an extra burden of side effects and an extra burden of risks, particularly when we have lots of other newer, safer drugs to use. The downside of drugs like ibrutinib and idelalisib, and to some extent venetoclax, depending on how it's used, is that they're quite long treatments. So ibrutinib, for example, is taken continuously until the treatment stops working or until side effects become a problem, and that can be many, many years, which is okay for some people. They take their pills and they're fine. Other patients have a problem with that because they feel like they're always on treatment. They might have low-level side effects that are bothersome and just affecting their quality of life. So conceptually, it is a bit different to traditionally how we've treated CLL, which is 6 months of chemotherapy, remission, stop. See you later, come back in a few years if you need treatment again. Concept compared to come and see me every 3 months and have your supply of pills and constantly having to look out for A, B, and C and have different monitoring. So I guess it's a shift in the paradigm of how we approach the disease, and there are pros and cons of both of those approaches. But considerations we should think about when a patient's CLLs come back. First thing to say is that we use the same criteria for treating again. So just because your lymphocyte count is rising doesn't mean you need treatment straight away. We still say, is it rising quickly? Are you anemic? Have you got B symptoms? Are your glands getting bigger? We use the same indications for treatment. We again look at the genetic risk profile. So we always look again for P53 because that's more common second time and third time round. We look at the previous treatment. What did you have? What did you have as your first treatment? How long ago did you have it? Some patients may have had fludarabine only 10, 15 years ago, and then they're quite different to patients who had FCR 1 year ago and then failed. They're quite different risk profiles. Of course, we look at the age and the fitness of the patient and what comorbidities, what other medical conditions the patient may have. And then we also ask the patient what they want, or the doctor should do that. I hope I do that most of the time. And we should always consider clinical trials because they're very important. They often have patient benefit. As long as you know and you understand the trial and you have a good understanding of what you're getting into and what the relative pros and cons are, I would strongly consider you to always look for an appropriate clinical trial. And most of the time in 2019, if your CLL has relapsed after first treatment, then most of the time you should be or will be offered a targeted therapy, ibrutinib, venetoclax, less commonly idelalisib. I think I've just done a brief summary of these drugs here. So ibrutinib is the most commonly used. It's pretty well tolerated. It depends on which populations of patients you look at. Maybe up to 1 in 5 patients or 20% of patients over time may have to stop the drug because of side effects, and those side effects could be serious, so serious bleeding, for example, or a serious heart rhythm problem, for example, in which case I'd be saying, look, I really think you need to stop the ibrutinib, I'm sorry. Or the patient may say, these side effects are really bothersome, my joints are aching, I'm really tired, and they're not serious, but they're really affecting my quality of life day in, day out. And it might be in those situations, sometimes we agree to stop the drug because of the quality of life impact. That's a minority of patients, but it is there, it is recognised, increasingly recognised, and is relevant. And then we think about particular side effects and risks. I mentioned bleeding, I mentioned the heart trouble, and there are various other things we should think about when we're considering whether ibrutinib is appropriate or not. But most patients will be suitable for ibrutinib, and most patients will tolerate it well. And for most patients, it works well and gives a remission of a number of years. The other option that we have available and is licensed and funded by the NHS is venetoclax plus rituximab. So this venetoclax is a tablet drug, 4 tablets a day, that tells the cell to die, and we give it with, in this situation, we give it with rituximab. There are other situations where it's given on its own. And this is increasingly used. It's been licensed and funded more recently than ibrutinib, and it's challenging ibrutinib as it's competing with ibrutinib for second treatment. So when a patient now relapses after chemotherapy and when we're talking about their second treatment, we would discuss both options with them. They're probably similarly effective. They are different side effect profiles, and different patient preferences would come into play. This is a 2-year treatment. This is fixed duration, but it's 2 years, and that's based on the trial that was conducted that showed its effectiveness. So that's one potential advantage, is fixed duration treatment. The other potential advantage is that it's better tolerated in the longer term. The first few weeks are quite complicated. You have to have lots of blood tests, lots of visits to hospital. You might need an admission to hospital for monitoring, because the drug can work very well initially. It can kill the cells so quickly that chemicals are released that damage the kidneys, something called tumor lysis. And we know we're quite good at managing that now. We know how to handle it, but it's quite involved in the first month. You're coming to hospital at least twice a week. Lots of blood tests, lots of monitoring. Once you get through that first month or two, and you finish your rituximab after about 2 months, then actually it's probably better tolerated than ibrutinib in the longer term. So there are pros and cons of the different drugs. And lastly, I should mention idelalisib, which is licensed and funded, but this is only if your previous remission is less than 2 years. That was just based on the original trial that showed that it was effective. This has fallen out of favour. It's not used very much. Mainly because of its side effect profile. So the risk of serious infections is quite significant, and other autoimmune problems like diarrhea and skin rashes can be a problem. So it's still available. It's still a reasonable option. We've used it in selected patients for particular reasons, but as a general rule, it's much less commonly used and less attractive than the drugs above it. But it shouldn't be forgotten about, because it's an active treatment and it might be a good option in particular situations. Right, can we afford all of this? Because the NHS has paid for some of these drugs, but we're increasingly using them in combination. These are, I don't read the Daily Mail, but you'll be pleased to hear. But these are headlines you may have seen over the years about all the different challenges the NHS is facing to pay for these expensive cancer drugs. And the problem with CLL is that the way the future is probably going is actually using these drugs in combination. It's not just having one expensive drug that, for example, in the States might be the label might be $100,000 a year, £100,000 a year. NICE definitely pays less than that. The NHS pays less than that. But can you imagine combining more than one of these drugs together and then having them for a long duration of time? It can become quite expensive for a publicly funded health system. So how the heck are we going to pay for it? Well, there are ways we can all influence it, I think. One is to develop the science, and I talked a little bit about that, understanding how the drugs work, why the drugs work, and understanding which patients will benefit from drug A or drug B, or which patients may only need drug C. So trying to be more selective and smarter about who we give the drugs to, so we're not wasting the drug, so to speak, on the wrong patient. Clinical trials are really important. And I'll talk about this in a minute, the current trial in the UK, using the drugs more intelligently. So perhaps giving more than one drug earlier on in treatment, and then stopping the drugs when a very good response has been achieved. And there's something called, that I won't talk about today in the interest of time, but something called MRD, minimal residual disease, which you may have heard of as a concept, which is our ability to measure tiny numbers of cells, tiny amounts of disease when the blood test is normal, when the scan is normal, to know how deep the remission is. So for example, some of these MRD tests can find one CLL cell amongst 100,000 or amongst 1 million normal cells, so like finding a needle in a haystack. And if we can use that test smartly to say patients have a very deep remission where you can't find 1 in 1 million cells, maybe those patients we can stop the drugs and give them a break off treatment for a number of years, saving money, saving side effects, and potentially avoiding resistance to drugs. So I think we're moving in a direction of trying to combine drugs together for a shorter duration of treatment and knowing when to stop the drugs. Certainly that's the concepts that we'd like to pursue. Pushing the companies, drug companies have got to make money. They spend hundreds of millions, often billions, developing drugs. They've got to make a return for their shareholders. But I think there is a role for us all, doctors, patients, and health organisations, to try and keep pressure on companies to try and invest in research and development of drugs and maybe give slightly less to their shareholders. But that's a challenge. And push the funders. We have a role as lobbyists. We've certainly lobbied as a UK medical CLL community, and I know the CLLSupports Association has, and I'm sure some patients has, lobbying NICE and lobbying NHS England to fund drugs, because there's always competition from other cancers and other medical conditions, and there's a rationalised health budget, and if we don't raise our voice and talk about CLL, then we have less of a chance of getting our drugs funded. So I think we have a role there. And I'm just going to show you now, I don't know, I've lost complete track of time, but I'm going to show you now the FLAIR trial protocol that I've mentioned a few times. I know there's some people in the room who have taken part in FLAIR or have taken part in some of the other trials that have informed FLAIR. So FLAIR's been running for a number of years now. It's a big trial, probably one of the biggest of its kind in the world, and one of the most ambitious, I would say. And Pete Hillman in Leeds is the chief investigator. He leads the trial. It's about 100 hospitals in the country are contributing patients, enrolling patients to the trial. And this is a trial that was designed for patients as their first treatment for CLL, and patients who are fit for FCR. So as a general rule, patients in this trial are under the age of 70. The trial protocol does allow patients up to 75 to go in, as long as they're medically sufficiently fit. And the idea of the trial, when it started in 2014, I think, was to see whether ibrutinib plus rituximab, and ibrutinib was in its very early stages of development. It was really only just licensed around that time for relapsed CLL, so this was quite a forward-thinking trial. We have our standard treatment, FCR, standard chemotherapy, still remains a standard in 2019 in this patient group. The R stands for randomization, and randomization is literally a random process, like tossing a coin, as long as you do it properly, to allocate a patient who's suitable for the trial to either the standard treatment FCR or a chemotherapy-free treatment, so a treatment that has no chemotherapy as first treatment. And initially the trial, because it's changed, initially the trial was designed to give half the patients FCR, half the patients ibrutinib plus rituximab, so the same antibody drug, and to see which was better in terms of the duration of remission. At the same time, there were smaller trials going on at the bottom. And I won't go through all the detail of this, but the smaller trials were trying to discover trying to work out whether the newer drugs that were coming through at the same time, because it's a constantly evolving field, so you can design a trial of A versus B, and then in a year's time you've got another drug to contend with. So you have to kind of keep ahead of the game and try and do things dynamically, which is very challenging actually. At the same time, there were smaller trials going on, funded by Bloodwise, the charity, through what's called a TAP program, to try and work out whether there was any other drugs we could bring into FLAIR, acknowledging that the field was moving on quite quickly. So to cut a long story short, a number of trials were done. And a couple of years ago, probably I lose track of time, but maybe 2 years ago, FLAIR was changed. So we learnt two things at this point. We learnt that adding rituximab to ibrutinib probably didn't give any benefit compared to ibrutinib alone. And there were a number of reasons for that. There was a trial in America, and there was some data from this trial to say ibrutinib is probably doing 95% of the work, and rituximab may not be adding much benefit. So the trial changed, so the rituximab was dropped, and so we were left with FCR plus ibrutinib, and then a new arm was added, and this new arm was added. This was a very pioneering trial. This trial called Clarity, which is only 50 patients in the UK. Who had it was quite an experimental trial because it was giving ibrutinib plus venetoclax, these two drugs that work in a different way, one against cell growth, one promoting cell death, so a kind of nice concept in terms of killing cells. 50 patients took part in this small trial to prove that this combination was both safe and effective, and there was enough confidence, there was enough evidence from these 50 patients, there's about 7 or 8 in Nottingham, I know at least one person's in the room, to use this combination as a first treatment for CLL, for someone who's never had treatment before. So this was quite a pioneering trial, and so now, as it stands, patients who are going into flare, and there's still a number of places left, I think it's got about another 6 months to run, will have a 33% chance of a three-way randomization, so a three-sided coin is a computer-generated randomization of either getting FCR or getting ibrutinib on its own, or getting ibrutinib plus venetoclax. And we think this is going to be the most effective combination based on the information we have, but we don't know for sure. We know from America that from a trial in America, smaller trial, not as smartly designed, but a decent trial nonetheless, showed that ibrutinib is superior to FCR in terms of remission duration. We think that this may be the winning arm, but we don't know, and it may add some extra side effects. There may be additional problems. The only way of proving whether a drug is one treatment is better than another is in this randomised trial. So I think there's more than 1,000 patients altogether in the UK already in the trial, and it's in its final phase at the moment. So, and this is an example of where we're going. You can see how we've evolved to get rid of chemotherapy, or to try and get rid of chemotherapy, and to use not just one of the effective drugs on its own, but adding in more effective drugs that work in a different way to try and reduce the burden of CLL to such a low level that we might be able to stop these drugs down the line. And there are plans ahead to get to a situation where patients in the trial may be offered the chance to take part in a stopping trial, where we say your disease is under very good control. It may be under sufficient control that we can stop the drug for a while and give you a break off treatment. We're not quite there yet, but those plans are in progress. So using multiple drugs together for a shorter period of time might address the issue of side effects to some extent, might address the issue of financial toxicity, as we call it, for the NHS, and it might reduce the chance of resistance to, because CLL cells will develop resistance to these drugs. We're already seeing patients who have CLL cells who become resistant to ibrutinib by cleverly rearranging their genes to become resistant to that drug. So resistance is going to be a problem with continuous therapy, so we're trying to address that in this way. And I think I'm going to summarise now before my voice goes. Lots of questions there. I'm not going to go through them all. You can just look at those in the final few seconds. But I've addressed some of these already. I don't think we're going to be using single drugs sequentially. I don't think we're going to be committed to continuous therapy. I think we will use MRD, this way of measuring low levels of CLL, to guide therapy. So the deeper your remission, the less CLL you have in your body, the better the chance of stopping the drug or drugs for a certain time. I think stem cell transplant is still going to remain an option for the minority of patients for a number of years. CAR T cell therapy may replace stem cell transplant, but that's a very open question. And we've discussed a little bit about paying for these treatments. But if your CLL is in remission and you're doing well, you could get a job and pay some more tax, and that would help as well. I think I'm going to stop there just with some acknowledgements. So we've got a good team in Nottingham. My colleague and I, Dr. Smith, are the CLL consultants, and we've recently appointed a third consultant who's been my fellow for a number of years, Nicholas Martinez. So he's joining the team officially as a consultant in November. Many of you will know or have met Helen Knight, who was here earlier today, had to go off and pick up her kids from school, together with Faith, who's another nurse specialist who supports CLL patients. We've got some very good pharmacists, and the pharmacists are increasingly important for CLL because of the drug interactions with different drugs like ibrutinib and venetoclax, and they're very important at the implementation and monitoring of some of the drug side effects and interactions. And then the bigger UK picture, we have the trials are all done through the NCRI, which Anna Shue and Pete Hillman have been the two major players in the NCRI CLL group. Many of you will be familiar with the CLL Forum, which is a organisation where patients, scientists, and clinicians come together, educational role mainly. Bloodwise and other charities, of course, the CLLSupports Association, and other broader cancer charities who support some of the trials that I've been talking about today. There's lots of people to acknowledge. Everyone's not on there, but that's just a taste of contributors. And I think I'll stop there.